Hello, everyone, and thank you for attending our virtual infectious disease grand round of the Sudanese Infectious Disease Association. We are very pleased today to have Dr. Ayat Idris as a presenter today. Dr. Ayat Idris is the Senior Registrar in the Infectious Diseases Unit at the Medical City for Military and Security Services in Muscat, Oman, with over a decade of experience in internal medicine, critical care, and infectious diseases. She holds an MBBS from Nile College in Sudan in 2014 and a membership of the Royal College of Physicians MRCP UK in 2019. Her clinical background spans major tertiary hospitals in Oman and Sudan, where she has managed complex medical and ICU cases. Dr. Idris had a strong academic record during medical school, graduating top of her class out of 130 students and receiving the Best Academic Performance Award twice, along with multiple prize awards for top performance in medicine, surgery, obstetrics, gynecology, and pediatrics. She is also an active clinical researcher with several PubMed Index publications in infectious disease and critical care, and has participated in global training programs including the MSF Global Health and Humanitarian Medicine course. She is passionate about medical education, and she previously served as a teaching assistant and continues to mentor junior doctors in postgraduate exam preparation. The floor is yours, Dr. Ayat.
Thank you, Dr. Azadin, for the nice this presentation, and I would like to thank Sudanese Infectious Diseases Association for giving me this opportunity to present 1 week of ID in Oman. So today, my presentation will be through the lens of an ID, a day, a diagnosis, a discovery, and every day in ID is an amazing day. This is where I work from the north of Sudan. I came to Oman. I work in this hospital. This is the place where the magic happens. I don't have any disclaimer. I didn't diagnose these cases myself. I was part of an amazing team who diagnosed these patients. Let's start with case number 1. She's a 21-year-old female. She was newly diagnosed with advanced retroviral infection after a screening for constitutional symptoms and AIDS-related wasting syndrome. She had a very long-standing diarrhea and negative initial workup, including colonoscopy and biopsy, that didn't show any features of CMV colitis. Parasitic stool PCR was done. Everything was negative initially. CD4 count was only 14 at the time of diagnosis, and her viral load was 79 kcopies. Her weight was only 32 kgs. She was basically skin on bone. So initial management. As I mentioned, we had an extensive workup to rule all opportunistic infections, and everything was negative. So she was started on dolutegravir, FTC-TDF, which is a combination antiretroviral therapy with cotrimazole prophylaxis, as she had a very low CD4. She had persistent refractory anemia. Initially, she had menorrhagia. We assumed it's relative, was treated with IV iron blood transfusion, repeated evaluation again for diarrhea and anemia, and it was only iron deficiency anemia that we picked up. She had a mild CMV viremia. There was no disease at that point, and she was on monitoring, and her viral load was dropping. So 4 months after an ART, she was admitted in a local hospital. We received a call from there that your patient's hemoglobin is 5. They transfused her and they contacted us. We arranged an admission for her. An EGD was done. As you can see here, it shows like evidence of gastric erosion. There was only like gastritis and part of duodenitis. Her weight was only 28. We were questioning ourselves why she's not gaining weight, why her diarrhea continued. There was no fever or night sweats. Her abdomen was slightly tender in the epigastrium. There was no organomegaly. We are going to repeat the extensive workup to answer this question. Our differential at this point, it could be an opportunistic infection, especially MAC, CMV, cryptosporidium, TB, possible malignancies like Kaposi and lymphomas, malabsorptions as well, and mineral deficiencies. Others like iris, HLH, and parvovirus 19. The workup included PET scan, bone marrow culture, a lot of things. And her PET scan only showed, as you can see here with the arrow, it only showed a duodenal uptake. There was mild reactive abdominal lymphadenopathy, but there was no sizable lymph node to be biopsied. There was no organomegaly, there was no bone marrow uptake, and no other uptake apart from this part, the duodenum. The OGD as well was consistent with the picture of duodenitis. So the biopsy showed, the duodenal biopsy showed features consistent with Mycobacterium avium complex, which is an ill-defined granulomas, and few AFBs were seen. At that point, when the first OGD was done, there was no culture sent from the biopsy. It was only biopsy sent for histopath, and this is what the histopath report. Her bone marrow culture as well showed a Mycobacterium avium complex. So at this point, we got our diagnosis of disseminated MAC infection. So it's a systemic disease, it's silent disease, it has a hidden complexities. Our patient was started on clarithromycin, ethambutol, rifabutin, and we added IV amikacin because she was severely ill. Her course of treatment was really challenging. She had elevated ALP, ranged LFTs that require changing of treatment multiple times. We switched rifabutin to ciprofloxacin, and we added for CMV viremia AIV ganciclovir. Then she has been neutropenic. We stopped it again. We rechallenged her with ganciclovir. Her weight gain was really minimal, and the diarrhea continued. Her albumin was only 13 at that point. What are we missing? Is she's not improving due to a wrong diagnosis or a treatment failure? Not just a GI bug. What other causes of low albumin in HIV patients? It could be HIV enteropathy, either due to the viral effect or due to the opportunistic infection with MAC that she's having. It could be HIV nephropathy, but that was excluded because there was no significant albuminuria. She was evaluated thoroughly by our nephrology team, and there was nothing suggestive of HIV nephropathy. Opportunistic GI infections, other than like Cryptosporidium, Giardia, CMV, Clostridium, all were negative. Intestinal TB as well, TB gene expert was negative in her case. Lymphoma, PET scan didn't really show any uptake that's suggestive of lymphoma. Severe malnutrition, she was severely malnourished and she had low albumin, but it could be as well due to malabsorption. ART-related gastrointestinal side effects. These all possibilities we were thinking of. And we re-evaluated our approach. And here is an AI-assisted diagram of how to approach of chronic diarrhea in HIV patients. It starts from infectious causes like CMV colitis, which is one of the common causes, and it can be a co-infection with MAC, Cryptosporidium as well, C. diff, TB enteritis, iris enteropathy, HIV enteropathy or lymphtelangiectasia, drug toxicities as an infectious causes, and others. So we did a capsule endoscopy for her, and these were the findings. These small spots, white snowflake appearance of the villi, and diffuse patchy whitish spots and plaques, and diffuse mucosal atrophies, as you can see here. There was no focal mass, no obstructions. We had a discussion with our gastroenterologist, and they believe this is consistent with intestinal lymphangiectasia seen in HIV enteropathy or in other protein-losing enteropathies as well. So we had an MDT meeting again with gastroenterology, dietitian, and she was started on elemental diet. Here is a little bit of understanding about losing enteropathy in HIV patients. As you can see, the etiology is the direct effect of the virus itself or opportunistic infection, as in our patient case, MAC infection. Clinical features is usually chronic diarrhea, weight loss. The pathophysiology, as I said, direct effect of the virus or the opportunistic infection, which causes villi atrophy that increase the permeability and protein loss. The treatment is nutritional support and ART. So patient was on ART, she was on MAC therapy, as I said, that was continued. She had initial improvement in the systemic symptoms. Diarrhea was ongoing but stable. Nutritional support with elemental high protein diet and low fatty acid diet. There was no new infection identified on the GI workup. She had a limited sigmoidoscopy due to friable mucosa that didn't show CMV colitis or lymphomas or any Kaposi or anything. Her labs were stable, CBC was stable, hemoglobin around 7. Inflammatory markers were decreasing. On day 59 of admission, she was ready to go home. She was doing well. And then we received a call from biochemistry. Hello, this is biochemistry. Your patient's calcium is 3.3. What? Everybody paused. She's febrile, clinically doing better. But now this calcium. Workup started again and again and again. Is it parathyroid? Is it bony meds? She had a recent bone scan and a PET scan. Is it vitamin D toxicity? What could be the possible cause? Her PTH was suppressed, which is parathyroid hormone, and her 125 dihydroxycholecalciferol was 1 in 10. Fantastic. Our patient is irising. So this is a diagrammatic, again, AI assisted generated, just to give you an idea about irising in MAC patient with hypercalcemia. There is no universal diagnostic criteria for irising. Irising sometimes is, there are two types, either masking or unmasking. It's a paradoxical worsening of a pre-existent infection, or it's an inflammatory process when iris happens. Iris usually happens when, to start with, the patient have low CD4 count, okay, and the patient is profoundly immunosuppressed. We initiate ART, then the immunity start to be boosted, inflammatory symptoms start to appear, CD4 counts are waking up now, and they are elevated, and they are starting to respond to the pre-existing infection. As I mentioned earlier, our patient has a granulomatous inflammation, which is a MAC. That is a granulomatous disease, but she had ill-defined granulomas. But now it seems that these granulomas are well-formed, and when granulomas are well-formed, they produce this alpha-125 dihydroxycholecalciferol, which is leading to increased calciferol level and hypercalcemia that is independent of parathyroid hormone. This is diagram also explains what happened in our patient's case. So MAC infection, where she had an undetectable or very low CD4 count, and there was no granulomas to start with. As I mentioned, there was ill-defined in histopathology. When ARTs were initiated, MAC infection increased the CD4 count, and granulomas started to be more obvious. More granulomas, more 1-alpha hydroxylase activity in the macrophages, more alpha-1 hydroxylase, more 125 increases calciferol activity, and this increases and leads to hypercalcemia. Our patient CD4 count were not high when we repeated, when she had this hypercalcemia, but we believe that whatever CD4 count were recovered, were recruited in the macrophages or in the granuloma formation. That's why it's expressed as high CD4 count in her blood. So let's talk about disseminated MAC in few slides, and then we'll talk about iris hypercalcemia. So MAC is non-tuberculous mycobacteria. It has two components, Mycobacterium avium and Mycobacterium intracellular. NTM were first identified in the 1950s, 59 especially. They were called anonymous mycobacteria, and then the famous American microbiologist, Dr. Runyon, reclassified them and called them atypical mycobacterium. MAC is a slow grower, typically hematogenous spread in advanced HIV patients. Typically, CD4 count is less than 50. They are an ubiquitous environmental source. There is no documented person-to-person transmission. Transmission could be through GI or respiratory, and then hematogenous, as mentioned later. This is the Runyon classification of mycobacteria. He classified them into 4 groups. Group number 1, photochromogenes, which they are producing pigment on exposure to light, and these are the slow growers like Mycobacterium gansesi and Mycobacterium marinum. Photochromogenes, which produce pigments when they are grown in the dark, like Microbacterium sclerophyllum. And there is non-chromatogenes, which they grow without any pigments, like MAC, avium and intracellular, and chimera. Chimera sometimes is classified again, with Mycobacterium complex, but it's look like Mycobacterium complex. Ulcerinus, Shemii, and others, as well Hemophilium in this group. And the fourth group is the rapid growers, which are mainly Mycobacterium abscescens and Chelonia. So there are the possible sites where Mycobacterium, or sorry, non-NTMs usually causes infections in immunocompromised patients. Pulmonary, which can be either MAC complex, Mycobacterium gansesi, abscesses, Shemii, these are all possible organisms. Cervical, usually avium, which can be because it causes disseminated disease, it can be in each part of NTMs. Bone and joints, and these usually, as I said, MAC, Hemophilium, gansesi, and others, skin and soft tissue, Hemophilium, Ulcerinus, Chelonia, and abscesses. And disseminated infection is usually by Mycobacterium avium intracellular or Hemophilium. So what are the risk factors of being infected with Mycobacterium, with NTMs? As I said, CD4 counts of less than 50, very high HIV viral load, delayed ART or IRS post-ART, prior colonization in patients, high-risk settings in areas where contaminated water and low-income settings. Clinical presentation, it's a subacute systemic illness where usually patients will present with fever, drenching night sweats, cachexia, mainly GI symptoms, chronic prolonged diarrhea, abdominal pain, hepatosplenomegaly, hematological like cytopenias from bone marrow infiltration. This is often confused with disseminated TB or lymphoma in HIV patients. So the diagnosis is mainly with blood culture, mycobacterial blood culture. Actually, this picture is from the mycobacterial blood culture that we got from a nearby institute because we didn't have it. Our intern was an amazing. She drove to the other institute and she got the tubes where we collected the blood for our patients, and it flagged positive 3 weeks later. From bone marrow, you can diagnose, or liver biopsy in case there is liver infiltration, where you will find the granulomas and AFPs. Imaging, there is usually abdominal nodes, splenomegaly, often non-specific. Consider dual infection if the patient is not responding to treatment with others like CMV and TB, especially in very low CD4 count patients. So what are the possible treatment regimen? Actually, DST or the drug susceptibility testing is essential in the appropriate clinical setting, as resistance sometimes is not uncommon. Our patient, unfortunately, we don't have the DST in our institute, and it was not done in Oman, but we were planning to send it abroad. Azithromycin or clarithromycin plus ethambutol plus or minus rifabutin in extensive refractory diseases. Aminoglycosides like amikacin can be added in disseminated disease to help in reducing the bacterial burden. The duration of treatment is 12 months or more, or until CD4 count recovery of more than 100 in more than 6 months. ART initiation do not delay, can be delayed to 2 weeks unless patient is severely ill, where you have to start treatment immediately. Macrolide resistance carries a poor prognosis, and quinolones can be added in this stage. I'm not going to discuss about NTM resistance and drug susceptibility testing because this needs a whole another lecture. So what about iris related to MAC infection? Typically, it presents with lymphadenitis, high-grade fever, new focal findings, or worsening of a pre-existing symptom. Atypically, it can present as hypercalcemia, as happened with our patient. It's managed usually with continued MAC therapy, plus corticosteroids if it's CV. High risk, if high iris risk, if ART started early in undiagnosed disseminated MAC. We caught up this case report of hypercalcemia secondary to iris in an HIV-infected individual with Mycobacterium avium complex. I'm going to share the references by the end of the presentation. So how you can prevent it and what are the prognostic factors? Avoid prophylaxis if ART are going to be started immediately. You can use azithromycin prophylaxis if CD4 count if less than 50, or ARTs are going to be delayed due to other factors like cryptococcal meningitis or other diseases that will require delayed ART initiation. Mortality is usually improved with early detection and immune reconstitution. Monitor for relapses in patients with delayed immune recovery. So what we got from this case, suspect MAC in a persistent diarrhea despite a negative workup. Always assess for iris in sudden clinical deterioration, post-ART initiation, hypercalcemia and low PTH, consider granulomatous disease. Interdisciplinary care is crucial. ID, GI, hematology, and nutrition. I'm recovering from flu and just a second. MAC enteropathy typically affects distal small bowel, but jejunal involvement is possible as well. ART reinitiation in disseminated MAC may trigger a paradoxical iris. Continue ARTs unless life-threatening. So follow-up of our case, she was continued on ART and anti-MAC therapy. CMV treatment continued and her viral loads were coming down. Hypercalcemia was treated with IV fluids, calcitonin, and zoledronic acid. She was discharged in an improved state. We saw her 1 week earlier and she's gaining weight and looks much brighter. So let's go to case number 2. This is a 51-year-old male. He's alcoholic. He had AKI, advanced retroviral infection. He was not on treatment. His viral load was very high.
1 second. Zadine, do you want to stop here, like talk about the first case, or you want to do the 2 cases together? And then see if you have any questions or anything. Thank you, Ayad. Great case.
Yeah, how many cases you have? We can, if you, and whatever you like, what do you think the best format? You want people ask questions?
I have 3 cases. Because somehow the second case has the related diagnosis to the first case. Let's just finish them and then we can discuss.
Okay. Sounds good. Thank you.
Okay. So he's a 51 alcoholic. He had AKI, advanced retroviral infection, was not on treatment due to denial. He had a viral load of 818K copies and CD4 count of only 10. He presented with seizure. Later on, it was due to delirium tremens as his brother just took his alcohol away. He had cough for 1 month, weight loss, anemia, hemoglobin 8.1. His initial workup for the seizure showed negative crack from serum and from CSF. His TB was negative from BAL and from CSF as well. He had upper and lower GI endoscopies for the anemia, and they were normal. CMV was not detected in blood or in the biopsies of GI endoscopies. He had lower limb weakness and he was immobile for almost 2 months. His nerve conduction studies and his MRI spine were consistent with peripheral neuropathy, possibly due to chronic alcoholism or an advanced HIV state. He had AKI, as I mentioned, and renal biopsy showed interstitial nephritis. He had severe co-trimexazole allergy, required ICU admission in his stay. Later on, we kept him on bentamidine prophylaxis because, as I mentioned, he was co-trimexazole allergic. We kept him on ART, dolutegravir, TAF, and FTC because I mentioned he had acute kidney injury. We continued physiotherapy for him, and he stayed with us for 21 days. On day 21, he started to spike fever and worsening cough. His oxygen saturation was 99 of oxygen. His HRCT showed bilateral scattered nodules. He had BAL at that time, bronchoscopy and bronchoalveolar lavage, was sent for TB, and TB gene expert was negative. There were no FP seen. galactomannan was negative as well. The differential diagnosis at this point was iris, PGP pneumonia, CMV pneumonitis, TB, bacterial pneumonia, fungal infection, iris, as I said, drug-induced pneumonitis, drug hypersensitivity reaction, HIV-associated lymphoma or Kaposi sarcoma as well. So his BAL 3 weeks later grew an NTM. At this point, we didn't know what was the final identification. We just had the growth. So we managed him in a line. Initially, we started him empirically on IV antimicrobial therapy, peptides, and he was no clinical improvement. We covered him with voriconazole. As I mentioned, fungal infection or invasive mold infection was one of our differential diagnoses. And he had slight improvement, not really significant. Once we had the growth of NTM in the BAL, we started him on clarithromycin, rifampicin, ethambutol as an empirical as well, because we don't know the NTM what will be. So 4 weeks later, we got the bug. It's Mycobacterium semii. As I mentioned, when we got the diagnosis of Mycobacterium semii, our patient was already 4 weeks on NTM empirical therapy. He had clinical improvement. We didn't perform, unfortunately, a DST or drug sensitivity testing on Mycobacterium semii. He was on ethambutol, clarithromycin, rifampicin. We know that Mycobacterium semii could be resistant to rifampicin and ethambutol, but clarithromycin is the cornerstone of treatment. Our patient had clinical and radiological improvement. Unfortunately, he was so well to that extent we couldn't even get another expectorated sample of sputum so that we can send it to know whether is it a true bug or a colonizer. Let's go through Mycobacterium semii, and I'll give you a question by the end of this case. So Mycobacterium semii is an NTM, as we mentioned earlier. It's a slow grower, photochromogenic NTM. It's an environmental organism. It's usually found in water systems and soil, frequently isolated in Middle East, Southern US, Cuba, and India. It's often a colonizer, but clinical relevance must be confirmed. It has intrinsic resistance to many first-line TB drugs, including rifampicin and ethambutol. Commonly, as I said, resistance to them. Susceptibility testing is essential, but unfortunately, in our setting, it was not possible. It requires a prolonged multi-drug therapy if clinically significant. So, what the clinical manifestations? It usually manifests as similar to TB, where the patient will have, these are the clinical manifestation of all NTMs in general, not only Mycobacterium semii. Either will present as chronic pulmonary disease, lymphadenopathy, skin and soft tissue, rarely bones and joints. This is mainly in hemophilia. Disseminated disease as in MAC. Sometimes others that will cause disseminated disease. Diagnosed NTM pulmonary disease, it has a criteria. The patient should fulfill clinical, microbiological, and radiological criteria. Clinical, it's prolonged symptoms in a pre-existing lung disease patient or immune-compromised host where they have a progressive worsening of respiratory symptoms, shortness of breath, cough, hemoptysis sometimes. Microbiological criteria is 2 repeated samples, detection of the same species or subspecies, 1 from BAL and 1 from sputum, or 2 sputum samples in 2 different occasions, 2 days apart. Radiological criteria compatible with radiological abnormalities, either cavitatory or nodular disease or bilateral interstitial changes. Some patients with bronchiectasis, pre-existing bronchiectatic changes, it will be difficult to get the radiological criteria for NTM. So what is the pattern? As I said, usually it affects pulmonary as a chronic pulmonary disease. But what is the pattern of chronic pulmonary disease in NTMs? There are three distinctive patterns. One is fibrocapillary lesions. It's usually in the upper lobes in small older patients with a pre-existing lung disease, which is make it really difficult, sometimes challenging, to say whether your patient is truly infected or a colonizer. Sometimes it presents with nodular bronchiectatic changes in immunocompromised patients, postmenopausal ladies, non-smoking females with few lung nodules. It can present as well as hypersensitivity pneumonitis, like a hot tub lung, where the patient has an exposure to hot tubs, indoor hot tubs. This is as an AI-assisted just understanding of how the involvement of pulmonary disease in NTM patients could be ranging from localized to diffuse disease. Localized, like fibrocapillary, in the middle, like nodular bronchiectasis, or diffuse, like hot tub lung. This is as well the symptomatology of the patient, which starts as mild symptoms, nagging cough, or mild exertional shortness of breath. It goes to subacute symptoms like respiratory issues, like fever, cough in a moderate disease, hemoptysis, and chest infiltrates, and severe diseases where shortness of breath, hemoptysis, and oxygen requirements in other patients. So disseminated NTM disease due to MAC is frequently seen in advanced HIV patients. Isolated pulmonary involvement is usually rare. Pulmonary involvement in patients with disseminated MAC ranging only from 2.5 to 8% of patients with disseminated disease. The portal of entry, as I mentioned earlier, is through bowel or respiratory with subsequent hematogenous dissemination. The clinical and radiographic of Mycobacterium cancer pulmonary disease is similar to MTB. So there is no, as I mentioned earlier, primary prophylaxis is not recommended unless the patient is not going to be initiated in ART due to other diagnoses, or for patients who are not virologically suppressed while on ARTs, either due to limited options of ARTs or due to resistance. So our patient had follow-up. This was 4 weeks after initiation of treatment of Mycobacterium CMI. As you can see, this is the before imaging. This almost disappeared. Okay, so I'm bringing a question here. As I mentioned earlier, by the time we started empirical treatment of NTM, we didn't know the organism was Mycobacterium CMI, and our patient was started on ethambutol, rifampicin, and clarithromycin. By the time we got the result of CMI, he already had this clinical improvement and radiological. We couldn't get up a new samples for him. So we had this theory. Either we got lucky and our patient was treated and our isolate is not resistant because we couldn't perform the drug sensitivity testing, or the other theory that his immune reconstitution helped in improvement with MAC therapy. Actually, we didn't change his regimen because we had radiological and clinical improvement. The other theory that we continued therapy as I mentioned, and we didn't change the regimen. It could be other NTM that we didn't pick up. Maybe we pick up CMI, which could be a colonizer. But in patients with heavily immunosuppressed, especially advanced HIV patients, any NTM could carry a pathogenic possibility. So for him being really infected with Mycobacterium CMI that is not resistant, we are not sure for sure, is questionable. But we had our clinical and radiological improvement. We are continuing treatment. And then after all this finished, we had another sample. We had, this is a sputum sample we sent earlier that showed Mycobacterium cancer. Both of them, Mycobacterium CMI or cancer, would carry a pathogenic effect in a patient who is heavily immunosuppressed, an HIV patient with this HRCT, and he was clinically symptomatic. So I'm going to leave this question for the NTM expert. Okay, and if you want, we can discuss this now, or I'll go to the third case and then we come and discuss both cases later on, or what do you think? The third case will not take more than 7 minutes. Hello?
Yeah, I think you can, if you do the third case, maybe it'll be better, and then we can have
Okay.
If,
Let's go.
Okay. Yeah, continue.
Okay, Dr. Azzuddin, thank you. Let's continue. The learning point, let's just keep it for discussion later on, but consider Mycobacterium simiae in a chronic pulmonary disease, especially in immunocompromised patient, because it carries a pathogenic effect. It can be a colonizer, but clinical correlation is essential. Diagnosis requires species level identification and adherence to ATS and IDSA criteria, diagnostic criteria, which I mentioned earlier, radiological, clinical, and microbiological criteria. Molecular methods improve accuracy and speed the diagnosis. There is more than 200 NTMs nowadays, and they are easily can be identified through RNA 16S RNA sequencing. Frequently resistance to first-line TB drugs. Usually DTS is really required. Recommended treatment, a prolonged combination therapy of more than 12 months or till the patient CD4 count recover of more than 100 in more than 6 months. Monitor closely for clinical response and possible relapses. These usually in other immunocompromised patients rather than HIV, because if they already started dropping their HIV viral load and they started immunoreconstitute, usually relapse is very rare. So let's go to case number 3. So she's a 43-year-old female. She's non-case of advanced retroviral since 2009, but she was not on treatment due to social factors. She presented with fever of more than 2 months and constitutional symptoms, cough and progressive shortness of breath for 1 week. She was on examination, she was sick, febrile, hypotensive. Her O2 sat was ranging about 86 to 90s. Her ABG showed a BO2 of 69 and AA gradient of 37. She had high LDH of 368, reference range up to 280. She had a CD4 count of a single digit, which is 6, very high HIV viral load, and her initial CMV PCR was not really high. And this is her chest X-ray. As you can see, a bilateral interstitial changes. Our differential at this point could be BGB, severe due to the AA gradient, atypical pneumonia, viral pneumonia, and mycobacterial infection as NTM. We got our PCR, which is BGB PCR was positive, DNA was detected. We thought it's a piece of pneumonia. We started her on treatment with both trimixazole and prednisolone. She was continued to require oxygen with minimum improvement. 7 days later, our patient is still the same. She is still requiring oxygen, still short of breath with minimal exertion, and she had still cough. What would have been missed? What other possible diagnosis? We did a CT, HRCT, which showed diffuse bronchial wall thickening, scattered very bronchovascular ground class opacities bilaterally. Our differential at this point, would it be a BGB treatment failure? Is it resistance, which is really like not really well documented in the textbooks. Other viral pneumonias like CMV, HSV, adenovirus, possible influenza, bacterial pneumonia. She was in hospital, but she didn't even improve and then worsen. No, she was statically not improving. Possible fungal infection, TB, NTM, pulmonary disease, could be irising, but at that point she was not even yet started on ARTs. Drug-induced pneumonitis, pulmonary edema, but not that was not the case. Lymphoma or malignancy and underlying pulmonary disease, which was possible because she was not seen in the clinic since 2009. So we applied the Occam razor here. Is it a BGB non-response, or is it another simplest explanation? Occam razor is a rule that's saying the simplest explanation is usually the correct one. So is it a BGB on add-on something else, or is it a solely other diagnosis and BGB could have been only a colonizer? We thought in advanced HIV patients, another diagnosis may explain the pneumonitis. And as I mentioned, she underwent bronchoalveolar lavage and bronchoscopy, and that showed this. This is what her CMV PCR in BAL. As you can see, it's 6.25 logs, and this is her CMV in the plasma, 5.8 logs. As I mentioned, her earlier CMV PCR in plasma was only 2,000, and this is even I cannot pronounce. So what is the primary cause? Is it a pneumonitis due to CMV or BGB? As I mentioned, we apply the Occam razor theory, and we believe this could be CMV pneumonitis, and BGB could represent only a colonizer. So what is CMV pneumonitis? CMV is also known as HHV5 DNA virus. The first adult case of CMV was described in 1925, almost 100 years now. CMV infection is an asymptomatic or manifest as a mononucleosis-like symptom in an immunocompetent host. It causes significant morbidity and mortality in immunocompromised hosts, mainly in transplant patients. CMV pneumonitis is a rare diagnosis. Even in HIV patients, it's a rare diagnosis. CMV infection equals CMV viremia. CMV disease means CMV infection, which is viremia plus attributable clinical features of CMV disease, which manifest as a viral syndrome or a tissue invasive disease. Examples are pneumonitis, retinitis, encephalitis, hepatitis, esophagitis, and colitis. I just wanted to mention that the circulating CMV viremia does not really correlate with the CMV disease. If you have CMV pneumonitis or encephalitis or colitis, you need a tissue diagnosis. You need a CMV PCR from the tissue and histopathologic evidence of CMV disease to label your patients as CMV. So CMV pneumonitis, lungs are the second most common site of CMV infection after the kidneys. This is mainly in transplant patients. In HIV patients, it's mainly the gut and then maybe the lungs. Clinical symptoms and radiographic features are non-specific. Patients may present with constitutional symptoms, shortness of breath that may mimic any other pulmonary disease in HIV or in advanced immunocompromised patients. Tissue invasive CMV is the gold standard, as you can see here, the owl eyes inclusion bodies. These are the diagnostic for CMV. Viral load in BAL is 100% specific, especially if it's more than 5 logs, because CMV can be shedding in the body fluids. Like you can have a CMV PCR detected in BAL. That does not mean CMV pneumonitis if you didn't find the owl eyes. And if the log was really low or the viremia was really low, this could represent only shedding, not really a true invasive disease. So you need logs of more than 5. CMV pneumonitis along with CMV PCR as well. So the case follow-up, there was no evidence of eye disease, fortunately. She was commenced on induction anti-CMV therapy with ganciclovir for 2 weeks, followed by maintenance therapy with Valgan. She had excellent clinical response, complete resolution of cough and shortness of breath. She had follow-up serum CMV PCR, which was negative. She was commenced on ART, DTG, and Truvada. For DTG is dolutegravir, TDF is tenofovir, FTC is amitriptyline. Was started by time of discharge with good tolerance. We saw her 6 months after that. CD4 are recovering, more than 100 now, and her viral load is undetectable. So what are the learning points from this case? In patients with advanced HIV and respiratory symptoms, lack of improvement on standard BGB treatment should prompt re-evaluation. CMV pneumonitis is rare but serious opportunistic infection in severely immunocompromised hosts with CD4 less than 50. Diagnosis requires bronchoscopy with valve accompanied by CMV PCR culture or else eye inclusions in cytopath. Imaging may show diffuse ground glass opacities mimicking BGP. Isolated CMV viremia, as I said, does not confirm the disease. You need PCR for a tissue invasive confirmation. Gacyclovir or Valgal is the treatment of choice. Therapy is often prolonged. There is no cut-off clear guidelines like in CMV colitis, where we have a clear guidelines. Sorry. ART initiation or optimization is crucial to improve immune reconstitution and to prevent recurrence. Thank you. I would like to thank you for your attendance and attention. I would like to thank my colleagues in ID team, infection control, microbiology in my hospital, medical city of military and security services, our colleagues in CPHL, which is the Central Public Health Lab in Oman, our colleagues in SQH, Sultan Qaboos University Hospital, our GI team, our pathologists, biochemists, and our nutritional team, and definitely our nurses and our patients. And the floor is open for discussion.
Thank you, Ayat, for the excellent presentation. Maybe if you can put in the first case slide, like the clinical course, just for people to remind them, and then can open the floor. I know Khalid will be itching to ask questions.
Yeah, this is the first case.
Go ahead, Khalid.
Yeah, thank you so much for your presentation. Like, very interesting case. So my first question to you, I think that's the question that everybody has. Why are these patients with AIDS? I mean, this is just, is there an issue, or like these are immigrants, they come with like poorly controlled? So I have a comment on multiple questions, but what strikes me is that you see a lot of AIDS patients, and this is kind of like really alarming, I think. So if you like mention a few words about this, and then a few questions. I mean, when like just speaking about NTM patients, most of the time when patients have like a really CD4 count less than 50, a lot of these patients, whenever like when you start the antiretroviral therapy, they sometimes recover spontaneously without even therapy directed against the pathogen. And here I'm just looking at case 1 and case 2. I'm like really thinking that this might be just the ART therapy, the immune reconstitution that actually led to recovery from the infection. In patients who are not having HIV or AIDS, like now we routinely screen, like especially those patients who get like recurrent NTM infections, we do the Mendelian susceptibility to mycobacterial disease and gamma interferon autoantibodies. So just like for everybody, these are like kind of the immune screening that you can do. The Mendelian susceptibility to mycobacterial disease, and also the autoantibodies against gamma interferon. So this might be sometimes helpful in case of recurrent mycobacterial infection. Then a small comment here about the use of rifamycins in NTM patients. So like I'm talking specifically about MAC and to some extent the mycobacterium semi. So there's ongoing discussion now, and soon you're going to see the guidelines change. They're going to drop the rifampin or the rifamycin from treatment of MAC and also other NTMs, and that's mostly because the rifampin, that it increases the hepatic enzymatic activity, so it will chew the other drugs, so lead to increased metabolism of the azithromycin and ethambutol. So now my standard practice, whenever I can, if there's a patient with MAC, I replace the rifampin with clofazimine. Okay. I know there's a lot of words about like using clofazimine in AIDS patients, but generally speaking, there was like risk of like increased mortality with using clofazimine. But in general, like if you guys have access to clofazimine, you've replaced it with rifampin, that should be much better. I will share some literature with you guys later on. The question that I have for you about the second case in particular, so this is like a nodular and bronchiectatic disease. So the first infection was CMI, the second infection was cancer CI. Was the patient
Actually,
like doing
the
any?
samples were taken at the same time.
Okay. Okay. So that's something. So for CMI, sometimes can be colonizer, but if you look at the guidelines, mycobacterium cancer CI always need treatment, unlike the other NTM infections. And then I just wanted to like highlight something which is really important. I don't know if that was done to this patient or no, which is the pulmonary toileting and airway clearance. When you see a patient with like recurrent NTM infection, it's really important that these patients should have like a flutter valve, hypertonic saline, chest rest. They should do this routinely because this is like most of the time, when you have like bronchiectatic picture, nodular underlying airway disease, these patients, like, they tend to this is a good breathing area. So they have to be on an intensive pulmonary toileting clearance for the airway that should be like going on all the time for most of these patients. So I just don't know if you use the pulmonary toileting but for the, I would be more concerned about the cancer CI. Sometimes you can do the watchful waiting, where basically you tell the patient do the airway clearance, like the flutter valve, the vest, the hypertonic saline for some time, and then repeat the culture after a while. If it grew again, then you treat it. But for the cancer CI, it should be treated as TB, and most of the time it needs therapy, unlike the other NTMs. So this is really fascinating cases. I'm like you're getting very good exposure to infections there, but I just wonder why do you have a lot of AIDS patients? Thank you. This was long. I'm sorry.
Thank you, Dr. Khalid, for your contribution. Just answering the first question, it's maybe just a part of me interested in HIV. That's why I chose to present these cases. We are seeing variety of cases, HIV and non-HIV, other infections. Actually, Oman is not considered one of the places where they have a lot of HIV cases. The epidemiology of HIV in Oman is less than 1%. It's only 2,800 cases we are having. Oman is a small country. The population is only 5 million. This is the first thing. Unfortunately, we are not seeing a lot of cases, but we are seeing advanced cases. We are still struggling about a delayed diagnosis of HIV. Those patients, all of them, most of them, they were diagnosed very late in advanced HIV state. Maybe that's why these infections, where they usually manifest in heavily immunosuppressed patients. We are improving currently the screening services. There is a premarital screening, there is pre-employment screening as well, and for expatriates or non-Omanis, absolutely there is every 2 years a screening for renewal of your residency card. So, and there are no expatriate cases.
Do you have a specialized clinic for like HIV? They get followed, people call them?
Yes, we have a clinic, and currently we have 100 patients in the clinic, and we are following them. 97% of our patients in the clinic are virologically suppressed.
I would just add to this point before you guys go more. Actually, Oman, they have they achieved elimination of mother-to-child transmission of both HIV and syphilis. That's one of the
very good
issue highlighted. Oman recently did.
Yes, in 2022, Oman achieved zero transmission for HIV and syphilis from mother to child. So it's part, as I said, part of me interested in HIV patients. That's why I brought this to the highlight. And the other part is, as I said, the complexity of these patients we are facing, and the lack of, how can I say it in a nice way, the lack of drug sensitivity testing. The second case, to answer your question, actually, this patient, when he first presented, there was no pulmonary disease. So he is not someone who has an underlying chronic pulmonary disease. As I mentioned, he presented with a profound immunosuppression CD4 of 10, and he was screened extensively, especially in the brain. In the chest, he had abdominal scan because he had anemia, and that abdominal scan showed the lower cuts of his lungs, and there was no evidence of any pulmonary disease. Initial chest X-rays as well didn't show anything. So while he was admitted for the workup of CNS disease and this lower limb weakness, he started to have this cough, and HRCT showed this. At this point, we sent 2 samples. We sent multiple samples. We sent sputum samples, more than 3 sputum samples. We suspected TB as well as NTM, and we did bronchoalveolar lavage. 3 weeks after the ban, we got the CMI from the ban. And at that time, I can say 100% the patient is not really fulfilling the criteria of IDSA for NTM, pulmonary disease, but Mycobacterium CMI carries a pathogenicity in HIV patient, especially with this very low CD4 count, and especially the patient has radiological, clinical, and only 1 sample from BAN, which was positive. So we started him empirically as treating MAC actually at that point. We started ethambutol, rifabutin, and clarithromycin. By the time we got the CMI identified in our labs, that was 4 weeks after initiation of therapy. So we paused. The patient is clinically improving. Do we need really to change the regimen? He has the disease, and this is not, you cannot, in an HIV patient say, because he had clinical and radiological improvement on therapy. So we couldn't assume that this is only a colonizer. We continued on treatment. 8 weeks after that, we got the result of that initial sputum sample growing Mycobacterium kansas. I totally agree with you. Mycobacterium kansas is more reliable, especially in HIV patient, as a pathogen rather than CMI. But as I said, the patient already 8 weeks into therapy, already he had clinical radiological. We couldn't get another samples because there was no sputum to expectorate. So we continued the therapy. I'm not expert really in NTMs, that's why I raised this question. Could it be possible that our patient has a CMI true pathogenicity that is not resistant to first-line TB, which is also a possibility given that our patient didn't have chronic lung disease to start with, had no prior exposure to TB medications. Usually those patients with Mycobacterium CMI, which is resistant, as I said, Mycobacterium CMI usually affects patients with pre-existing lung disease. So the risk factor of resistance in Mycobacterium CMI is a pre-existing lung disease or a pre-exposure to anti-TB medications, which is our patient didn't have. So maybe he was lucky and his CMI was not to start with resistant. Or it could be cancer, and he responded to clarithromycin therapy because that was the core therapy in patients with cancer. And I want to hear from microbiologists what they think.
Next, also we have Taha. I'm not sure if this is Prof. Taha or somebody else. You can go ahead.
Yes, thank you very much. Very nice presentation. I'm just curious. I actually hadn't mentioned this, and I'm curious as well. I mean, how, for the first case in particular, how did you come to, or what directed you to HIV being part of the diagnosis, especially if this is, I mean, if this is a native or immigrant or some other factor. But I am curious for the atypical mycobacterial infections, just like in B, would you start antiretrovirals first, or will you treat, or at least start for a few days, for a few weeks, the treatment of the mycobacterium before starting antiretrovirals, just to reduce the chances of iris?
So for the first case, actually, she was screened as part of constitutional symptoms, and unfortunately, she had risk factors for requiring HIV. So that's what brought the idea of HIV screening for her. Secondly, as I mentioned, initially, she had constitutional symptoms, she had prolonged diarrhea. So she was extensively evaluated. We did upper and lower GI endoscopy. We did CT scan of the abdomen. At that point, there was no lymphadenopathy. There was nothing to suggest MAC, and even her anemia was attributed to menorrhagia. She had really prolonged history of menorrhagia, and she was seen by gyne initially, and that's why, and blood cultures were sent as well, and they were negative. So we started ART treatment because there was no any contraindication to start them, and there was no any opportunistic infection identified when she was first diagnosed. The first diagnosis of MAC occurred 4 months after initiations of ART.
But generally, do you would you, for example, recommend just like done for TB, start antiretrovirals first, or the treatment of the atypical mycobacterium?
For MAC, you mean NTM?
Yes.
There is the guidelines are saying maybe you can wait for 2 weeks and then you can start the ARTs, unless the patient is critically ill, and then you start the treatment like together. There is no like in other well-documented guidelines, like in cryptococcal meningitis or in TB meningitis, where there is a clear guidelines. You have to wait prior to starting ART. That's why we started ART in her case. And actually, when we got the diagnosis of MAC, she was
Thank you.
Khalid, you can go again, and then Ahmed.
Just to answer Dr. Khalid's earlier question about toileting, our patients we didn't really perform like a bronchial toileting, but he was frequently seen by the physiotherapy for his lower limb, and he had few sessions of physiotherapy in his chest as well. But that was not really to clear the NTMs, to be honest.
Yes, thank you for this point. I mean, so again, the pulmonary toileting is like integral part of treatment. I mean, again, I just to reiterate on the first point that, like, you know, you can basically do watchful waiting in a case like this, wait for the immune system to recover, and then just do the chest like the chest physiotherapy is like the mild form of like pulmonary toileting. They need flutter valve, like vest and hypertonic saline. And yes, to just attest to your point, the AIDS info recommend actually to start the therapy directed against MAC for 2 weeks before starting the ART. Yeah.
Ahmed Abu Bakr.
Assalamu alaikum, Ayat. Thank you very much. This is an excellent presentation. And, you guys seen very complex cases with advanced AIDS, HIV. I mean, I was really surprised, and really I like the first case where you have very extensive workup for protein losing enteropathy and all of the finding on the capsule endoscopy. That's really very advanced. I'm really not familiar with the finding on capsule endoscopy on protein losing enteropathy. I don't know if that is pathognomic to see that visuals on the. Have you seen anything on the literature on that part? This is one question. My other question about the ART therapy of choice. You know that sometimes that with the new advance in kinase inhibitor and all of those, we have seen a lot of improvement with the viral load dramatically. So I was just wondering which ART you choose in the initial one, and have you seen any data on ART?
Dr. Ahmed, your voice disappeared. I couldn't hear the second part of the question about ART.
So the ART, regarding the integrase inhibitor, which is now the first line, and we know that bring the viral load very rapidly. So, and my understanding that with iris, you'll see more iris when you bring the viral load rapidly. So which one you choose initial for the first patient? Which ART you choose? And if you have come across any data on the ART therapy and iris, which one of them is is it the integrase inhibitor? Is it the old? Which one of them? Notorious for iris. Yeah, so these are my 2 points. The finding on the capsule endoscopy, is it pathognomic? And if you have seen any data on that. And the second one is the integrase inhibitor and iris, and which one of the ART you choose, and if there is any data on the high risk iris ART therapy.
Yes, thank you, Dr. Ahmed, for your question. Regarding the first part, the capsule endoscopy, like the same day she had the capsule endoscopy, the next day, our GI team approached us, and one of them, fortunately, he was working in a center where we had exactly the same case series of protein losing enteropathies. The pathognomic feature, these white snowflakes pictures, where is it? Just a second, let me put it. This image, this white snowflake, as per our gastroenterology team, these are called lymphatic lymphangiectasia, intestinal lymphangiectasia, which are pathognomic for protein losing enteropathy. In her case, we don't know if it's due to HIV itself or due to the MAC infection. Which started the first, the chicken or the egg, we don't know. But both diseases will cause protein losing enteropathy. And these are pathognomic for protein losing enteropathy, but not for the underlying HIV enteropathy. This is to answer your question. We've looked up into multiple case series, and most of the patients were having infections like MAC or even TB. There are few cases where there were no identified infection, and it was attributed only to HIV. But in all the cases, the pathognomic feature was the lymphangiectasia, which is the white plaques and the friability of the mucosa. This is the first part. The second part regarding integrase inhibitors. Actually, as I mentioned earlier, still in our clinic, we are using ivabirnase-based therapy. A lot of our patients, we are only newly started introducing integrase inhibitors in our institute. And when we diagnosed her, she was one of the very few patients we started her on integrase inhibitor. As I mentioned, her initial extensive workup didn't show any opportunistic infection. So we really wanted to drop her viral load rapidly. Maybe this is what happened in her case, and this is what made the CMV was the first iris, and the second iris was the hypercalcemia. But to start with, her viral load dropped to only 1.5 log. It was only 200, but still the patient, her CD4 count didn't improve. It was only, it started 14. When we admitted her for the MAC therapy, for like the MAC diagnosis, her CD4 count were still low, only 12. So I don't know if she irised. It was only the viral load who dropped, but not really the CD4 count recovery. At some point, we thought maybe she needs an immunological assessment. We tried to discuss with the immunologist, but we couldn't actually be able to reach them at that point. So I'm not sure if integrase inhibitor, actually I didn't look into data or in the literature if the very rapid drop in viral load due to use of integrase inhibitor based therapy will really lead to iris or worsening improvement in the immune status of the patients. I don't know if others have experience with this. Maybe they can answer this question.
Yeah, thank you, Ayat, for the answer. Just one, and the what is her last CD4 count, if you don't mind, like the recent one? Did she ever?
Yeah, the recent one, as I said, this iris hypercalcemia, it was on 8th of May this month, last month, 8th of May. And we sent, on the same day we got her high calcium, we sent CD4 count just to understand her iris mechanism. And unfortunately, it was still the same number, ranging 14, 16. But as I mentioned, she could have recovered CD4, and those CD4 who recovered could have been recruited in the granuloma formation, and they did not circulate in the blood, and that's why they were not detectable.
And the viral load.
So it's only theoretical part that she had iris hypercalcemia, but CD4 count that recovered were in the granulomas, not the blood. I believe this is theoretical only, because we cannot have evidence on it.
And the viral load is undetected.
Yeah, her viral load is less than 200. It's not yet
more than
suppressed,
5 months.
but less than 200.
And this is more than 5 months.
Hmm?
Her illness, like from the time of diagnosis up to today, more than 5 months.
Yes, she was diagnosed at December, and she got admitted. Diagnosed in November, and we got her admitted for evaluation in February, and we got the diagnosis of MAC by early March, and iris hypercalcemia in May.
I see. I think one point also, Ayat, you should consider and you should look into the sometimes with advanced AIDS, HIV, those patients, when they begin with severe AIDS defining illness and very low CD4 count, they will never recover for some reason. And there is a lot of data on that part, and I don't know what characteristic of population they have that phenomena, but we've seen it. So I think that's one of the things that you should think about it. What is the timeline, and what is the characteristic of those patients, and what kind of opportunistic infection they have, and your patient might be fitting on those category where he will never recover the CD4 count.
Yes.
But the viral
I've looked into this. Yeah. We had actually few patients in the clinic where they have virological suppression and they never recover the CD4 counts. The characteristics are mainly like how advanced they are diagnosed. Some patients, they will be having retroviral infection for many years, where their immune system really exerted all the lymphocytes, and they will be not able to recover it. It says very early age of diagnosis, like very young in childhood, or very old age of diagnosis. These people are usually, they won't recover their CD4. We wish that this is not the case in her, because she's young, she's only 21, and let's just give it a time and she may recover. We don't know. We assumed as well that one of the factors that she didn't recover her CD4 count was the neutropenia induced by ganciclovir, and the CMV viremia that she had, which contributed as well in the cytopenia she had, and this has led to inability of the CD4 count to recover.
Yes, and I think we can add something here. I mean, especially for the first case, when you have like severe malabsorption like this, probably the absorption of the ART and also the MAC therapy is like suboptimal, and you might be running into like subtherapeutic doses of all like drugs. And this is really challenging case. When we see cases like this, it's really hard, because like with the malabsorption, you have issues with the drug absorption, and it's just like a lose-lose case. I mean, there's no nowhere in the literature that IV medications can be used, and I'm not familiar with any IV ART that can be used, or even for the MAC, we always do oral, and it's just like we're running the risk of subtherapeutic drug levels. So
yes, I agree with you, Dr. Khalid. Her viral load were like less than 200, so it's not really suppressed, but it's at least reassuring that she's absorbing somehow
not too bad. Yes.
Yeah. For the MAC therapy, there is no like guidelines for how your patient responded to treatment. It was only clinical that she's gaining weight. It could be also due to the diet we started her on for the treatment of this protein-losing enteropathy. And as well, when we repeated the blood culture of MAC, the initial blood culture, we couldn't really like detect the heaviness of the growth, but at least in the second blood culture, we got We got the growth very late. So we assume that the bacterial burden at least has decreased. She's not yet cleared her bacteremia or the MAC from the blood, but at least it's not as the same as the initial one.
Thank you, Dr. Ayat, for the great lecture. Any more questions? Yusri, go ahead. Yusri, Dr. Yusri.
Hello.
Yeah.
Assalamu alaikum.
Alaikum assalam.
Ahlan. Assalamu alaikum wa rahmatullah. Ayat, thank you so much. Very, very interesting cases. We learned a lot. Clearly challenging cases, and very, very pleased to see everyone and see more names on the side of the screen. Just a few comments. I really, Khalid mentioned something about, pathogens that could be present, infection that with pathogens that could be potentially pathogenic in the early or late presentations like this, which tend to disappear spontaneously on the start of antiretrovirals. So that is a very important point, and not just the NTMs, but also CMV that you mentioned, and it seemed to be a common theme in your cases. In certain situations, they could just be present there, and in many settings, people did not even test for it. But I'm very pleased that you've been doing this on a regular basis, and you made that diagnosis of CMV pneumonitis, which is really rare, but very convincing. And you pointed out that there's no clear always correlation between the viremia and the tissue invasive disease. That you may find no viremia at all, but really severe retinitis or encephalitis or pneumonitis with no big viremia, and vice versa. So that's a very important point. The question was asking about the PCP in that case, because it was diagnosed first by PCR. What was the CT value at that time? Was it really too early, like 20, or is it? Do you measure that?
Actually, unfortunately, no, that was measured in that case. That's why, when the absence of response to treatment, we just continued the therapy, but the patient really improved after initiation of ART plus the ganciclovir.
Yeah, absolutely. I mean, it's clearly she had CMV and she responded well to the treatment of CMV. But maybe the CT value would have given you some clue. As maybe this is just a bystander, the PJB there in the, and I just wanted to also to ask Khalid about 2 points. One on the treatments of NTMs and the MAC. Did you in your like dual beta-lactams therapies, try to generalize this to cases like this and see if it can be used as a rescue or adjunct? So is there anything similar that is being done for dual beta-lactam therapy? And also you mentioned something about the antibodies to interferon gamma. So do you use egress or antibody to interferon gamma, or do you use a combination, and how do you do that? Thank you.
Oh, you don't get me started. So to answer your question, I mean, we've done some work on sepsis mainly, but we're able to apply this concept on other NTMs like MAC and others. But most of the work that we've done is on MAC and abscesses, and we've been getting consistent results. I can talk about this later on, but just yes. We've done the double beta-lactam, and in drug-resistant TB, when you have XDR TB, there is the amoxicillin clavulanic acid with meropenem. It's just the same concept. So TB, MAC, and abscesses, and some other rapid growers. But we've done the double beta-lactams, and I hope we were nearby that could have done the susceptibility testing for you, because especially for the first case, if this was macrolide resistant, this will be like really challenging. But again, I have to like like press on Yusri's point. When you recover the immune system in AIDS or patient, or when this immune system starts recovering, this is when you see all these infection disappears, including the CMV. Because Yusri gave us a really good talk not too far ago last year, I think, about the CMV. That sometimes it can, whenever they escape the immune system, whenever the immune system will get suppressed. So it's a kind of fascinating case. Yeah.
Dr.
But
Omar.
Yusri, can you tell us more about the CT value utility? I didn't understand the point.
Yeah. So in any PCR, of course, you just go through cycles, and it's like magnification power. So every time you do one cycle of the PCR, the quantity that is there, if it's there, becomes bigger to the extent that it becomes detectable. So the cycle at which a target has been detected, that would infer a bigger viral load or bacterial load or fungal
I
load.
get you. I get the utility of the CT, but what's your point here?
So it's a cycle threshold. For us, there is no a specific threshold because PCRs are different in their sensitivities. But in general, the commercially available ones, which tend to kind of have similar sensitivities, 30, a CT value of 30 is being used like a cutoff. So anything that is later than 30 is probably not not genuine infection, and you have to interpret it very carefully with the clinical picture. Things that are under 30 and definitely under 25, these are highly likely to be a genuine infection that need to be treated. So this case, maybe from the way it was described, if we had a CT value, would have been around the 30 or later than 30.
So you would just like think it's not contributing to the illness?
Yes. Yeah.
Okay. That's very
You
helpful.
you haven't told me about the gamma interferon.
Yeah. So the gamma interferon. So now, whenever we see a patient who's like not immunocompetent, presumed immunocompetent, we do the Mendelian susceptibility for mycobacterial disease, and we send the gamma interferon assay, both the assay for quantitative for the gamma interferon, but also we screen for the antibodies, autoantibodies against gamma interferon.
Thank you very much. Dr. Umar Rahman, do you have a question? Will be the last to conclude.
Thank you. I think Yusri touched on the point I wanted to talk about, but thank you so much.
Thank you. Well, thank you, Dr. Ayat, for the great presentation. This was very, very insightful, and we learned a lot today. And thank you for those who attended, and we hope to see you again next month, first Sunday of the month.